So one of the major goals of this study was to make a connection, or to see whether there's a connection between the amount of experience an obstetrician has and the quality of care that that particular obstetrician can deliver. I was really quite surprised by the results of this study. So if you had asked me beforehand, what did I think I was going to see, I was pretty sure that I was going to see that there was a gradual improvement in quality after residency that would plateau at around 5 years. I really didn't think that there was a lot we could teach an obstetrician who'd been out delivering a lot of babies for 5 years, maybe 10 years. Instead, we found that not only did quality improve to 5 or 10 years out, but it kept improving. That was a complete shock to me.
So there's been lots of studies on volume outcomes association, and we think the story is deeper than that. We're really looking at the association between experience and outcomes really at the physician level. No one's looked at obstetrics before, to our knowledge, and no one's looked at this such a long time period as we have.
Obstetrics is a really interesting case to examine for a couple of reasons. First of all, there are over 4 million deliveries in the United States each year, so it's a kind of high volume activity. Second, individual physicians, obstetricians who deliver babies tend to deliver lots of babies, and so that you can observe the quality of an individual obstetrician with a lot more resolution simply because they deliver lots and lots of babies. And third, in contrast to lots of other areas of medicine, which is increasingly becoming a team sport, obstetrical care is still largely about a single obstetrician, maybe some nurses, maybe an anesthesiologist, but we can attribute quality much more in obstetrics to a single person or a smaller team of individuals, and so it allows us to make a better connection between the experience of one of those members of the team and the outcome that a patient might receive.
Our measure of performance was based on their maternal complication rate. That is an average rate of complications among a given physician over a given year for his or her patients. Our measure of experience was based on time elapsed since the physician graduated from residency.
So one of the fundamental areas that this study attempts to address is, how do we judge the quality of the medical education in this country? If you were to ask me, I would say that the single purpose of our investment in medical education is the creation of a workforce that is capable of taking good care of patients and populations. But we tend to judge medical education by the scores that students get or young physicians get on a variety of pen and paper examinations. What we should be doing, I think, is judging the quality of medical education based on the kind of care that the graduates of our medical education programs deliver to patients and populations. So we should have a much more clinically oriented, outcome-based approach to judging whether our training programs are producing the kinds of doctors and other clinicians that we care about. This study, I think, is important, in part because it tethers clinical outcomes with medical education, and I would include within that experience. The more we can evaluate how good our training program is by how good the care is that the graduates of those training programs provide, the better able we are to generate and develop good training programs that serve the nation's needs.